So good afternoon everyone. I would like to thank AIOS for giving me opportunity today. So I have two cases here which is of suspicious topographies which I felt were challenging, and I would like to take opinion from the seniors here. So this was case 1, 29-year-old female. This was a BCVA with predominantly cylinder. She wanted freedom from glasses. So this was a right eye topography. Here you can see the anterior tangential curvature. There was some amount of inferior steepening. There was no significant posterior elevation. It was a thin cornea. The indices showed thickness of 467, 4.47 cylinder. The machine labeled it as borderline. The superior inferior asymmetry was plus 0.08, plus 0.82, which shows there is inferior steepening. And the aqueous depth was 2.66, which was below the cutoff for phakic IOLs. Similarly, the indices here, others were everything was normal limit, only the curvature asymmetry was there and the thickness was lower. Similarly, in the left eye, the anterior curvature showed a superior steepening. Again, no posterior elevation, again a thin cornea. Similarly, all the other parameters were same, aqueous depth was lower, and this was labeled as normal. Here the superior inferior symmetry was minus 0.26, which shows a superior steepening. So I'll come to the points of discuss later. So this was the second case, 22-year-old female, high myope with some amount of cylinder, came for refractive evaluation. This was a topography. All other parameters are normal, only the posterior elevation showed a isolated island of elevation. The scan was totally depicted as normal by the machine. The keratoconus summary also showed that persistent posterior elevation. She had a pentacam report done elsewhere which also repeated the posterior elevation, which was also seen on the BAD map. But the BAD D value was normal and it was not seen in the difference map. Similar picture in the left eye, no significant posterior elevation, thick cornea, but similar mirror image, the posterior elevation was seen again on the posterior elevation map. Thickness was normal, aqueous depth normal, the scan was also normal. Same repeated on the left eye, mirror image, posterior elevation. Similarly seen on the pentacam also. But again, the BAD D value was normal and the difference map also did not show any significant abnormality. So I would like to discuss these cases. I'll go back to the first case.
What was the refractive error for the second case?
It was a high myope. I'll just come minus 6 or 7. I'll just come minus 7.25, 6.75.
What is white to white?
Right eye was 11.84 and left eye 12.12. So can we ignore the posterior elevation? Can we go ahead? Should we observe?
It's not a posterior elevation actually. It's just a
Yeah, it's just a, yeah, that's what. So
you can go ahead
can we go ahead
for the
still?
second case.
Okay.
For the first case, I think
It's a high cylinder.
high cylinder, you can't go for PR guide.
Yeah, and phakic IOL also is ruled out because it is 2.66.
Frankly, I am not seeing that topography also normal.
Yeah, exactly. So case 1, leave it. Observe.
What is the refractive error here?
Case 1, it's minus 6 and minus 7 cylinder. Predominantly cylinder, there was no sphere.
Early keratoconus.
An ACD of 2.6.
But there's no posterior elevation as such in the map, and even machine says it's a normal scan, though it's a thin cornea.
So, too many things are standing out. The thin cornea, the high astigmatism, and I mean, even though the maps may look absolutely fine, still, I mean, the very fact that your corneal thickness is thin. I mean, I'm just saying that even if your map was fine and everything was perfect with such a thin cornea, I mean, and then correcting.
But
for
in
such
thin corneas, wouldn't the parameters be, they should not be reliable, right? Like,
no, not
generally.
So thin cornea by itself is one of the indices which it qualifies an eye to be put on watch. I mean, put on the card. So anyway, I mean, the first one is clear. Second one, I think you have those things on the
isolated
posterior.
elevation patches.
Yes. They can be artifactual sometimes, and
But
it
it's
depends
same
on
in the pentacam also, it's repeated.
Any
I mean,
subtle scarring or anything
Yeah, so
in
but
that
she said
area?
it's symmetrical
Nothing.
in both eyes.
Yeah.
That's a funny thing because sometimes you've seen in one and yes, you may have scars.
And
So
repeated on the
these are-
pentacam also. And I have acquired the scans like 2-3 times.
What about
with the-
epithelium maps in the second patient?
No,
You don't have access.
It's a
That would
posterior,
sometimes.
sir.
I know it's posterior, but I mean it would be worthwhile seeing what's on the surface as well sometimes in that area. And but again, it's a dilemma. So I don't know if anybody else has anything to add. I don't. Yeah, when in doubt, maybe ICL is a good
Second
option.
was ICL. Yeah.
Sure. So I
Relative
think-
pachymetry at that zone where there is an elevation would help actually to
Actually,
find
it's a
out
thick
where.
cornea. It's 600 in that.
But there was
the
no
relative
corresponding
pachymetry. I'm not talking
thinning
about
also.
the total the relative pachymetry. Individual map, relative pachymetry at that zone. That might give some clue.
that might give us some more information.
No, it's on a temporal side.
It's in the periphery.
There's no corresponding thinning also.
Corresponding thinning, it's not in the central zone, and it is, if it's bilaterally symmetrical, I don't think, we need to worry about it too much. If it was in the center, the posterior elevation is more in the central 4 to 5 millimeter zone, that's where you'd expect, or there was another red flag which was corresponding to the thinness of the cornea, then I would be more wary of that. So probably it's artifact.
Sir, would you do a smile extra for this patient?
I probably would, yeah. Yeah. Yeah, whenever in doubt, if you're doing a smile, you can switch to smile extra. It
No,
does give
smile
you-
extra or fake.
So, fake kick would probably be a wise choice here because smile extra still remains in a gray zone. I mean, for the sake of discussion, we could do that, but, if you have to give a message to the audience, I think it would be ICL. Yeah. So I think, thank you so much.
Thank you.